Welcome to AETCM, the emergency medicine channel. Shall I start, sir?
Yes.
A 57-year-old male patient, non-case of diabetes, hypertension and BPH history with the vesical calculi, post-TUR procedure and percutaneous histolithotripsy for bladder stone in the beginning of this month, presented to the ER with complaints of fever with chills and lower abdominal pain, moreover the right side, with nausea and multiple episodes of vomiting. On initial 10-second assessment, patient is conscious oriented, airways patent, no pooling of secretions. Breathing saturation is 100% in room air with respiratory rate of 16 per minute, air entry bilaterally equal. Circulation, BP is 8650 mm of Hg with pulse rate of 100 per minute and tongue is very dry and CRT is more than 3 seconds. At that time, we attached the patient to cardiac monitor and 18-gauge cannula was inserted and we done one USG bedside which shows IVC is collapsing with more than 50% collapsibility and fair LV. We started on IV fluids, IV 1 pint oral started and disability wise GCS is E4, V5, M6 with pupil bilateral equal and reactive, exposure afebrile at present. And GRBS is 89
milligrams per deciliter. So patient is
hypotensive.
Okay, 100.
And we do some adjuncts at that point. CBC CRP point of care which shows WBC of 19,800 and HB of 10.2. Platelet count is 232,000 and CRP of 152 and of neutrophil predominance 91%. And we done with VBG also which shows pH of 7.372 with the bicarb of 21 and PCO2 38. Sodium is 127 with potassium 4.3 and creat is 3.39. Baseline was 1.27 and lactate is 4.9.
Lactate is 4.9. So we have a patient who is in shock. And also the lactates is elevated, and because we know the baseline creatinine value, we know that there is an acute kidney injury on top of this thing.
Initially when we look the patient was severely dehydrated. IVC is collapsing, so we initially started on fluid resuscitation only. And for 1 hour we do the fluid resuscitation around 1.5 to 2 liters we give for assessing the IVC and also the output. Charting also done after Foley's catheterization. And
so how was it? Was he fluid responsive?
At that time not fluid responsive, since the repeat BP also shows the same level and also the lactate levels continues to be in 4.7, 4.9 level.
So the lactate elevation was
still persisting and the same BP is maintained. So that we started on small inotropic support also after 1 hour. After initial fluid resuscitation.
Post fluid resuscitation, you check the IVC.
IVC again. So it's initially it was completely collapsing like kissing kind of a type, and after fluid resuscitation also it is like more than 50% collapsibility is there. So we maintained on maintenance fluids. And at that. And after that we done one ECG also which shows normal sinus rhythm, no acute STT changes. And we came into a provisional diagnosis of most probably urinary tract infection which leads to urosepsis, AKI, and dehydration was also there in the initial stage. And after that because of the persisting hypertension and lactate elevation we come to and started on inotropic support. Sepsis shock component was also there. And we have to rule out pyelonephritis or any hydronephrosis, obstructive uropathy or urinary calculi also at that point, since the patient has pain from right side. And we also started the patient on IV antibiotics. Injection piperacillin tazobactam initiated after sending urine and blood cultures. Since the patient is in sepsis, we sent blood cultures also.
Blood culture as well.
And we initially took one USG abdomen pelvis in ER bedside to rule out right HN urinary calculi, obstructive uropathy or cystitis. And the report came out to have right-sided HUN also.
Right-sided HUN. Also. So if at all the patient, right-sided lower abdominal pain, it is flank pain, characteristic of something related to renal pathology itself. But if this patient, we should not be having a narrow view of only having urosepsis in our mind. We should also think about other abdominal pathologies also. Just saying. All right, moving forward. You started on piperazine and
tazobactam also, and we proceeded with CT-KUB also to know about the size and location.
Okay.
And we showed right VUJ calculi of 5 mm size and right HUN was there.
Okay.
So for that we done one urology consultation also. So coming to the ample history, patient is not allergic to any medications. 57-year-old patient, non-case of diabetes, hypertension, chronic retention of urine with BPH and vesicle calculi, post-TERP and PCCL on 2nd of this month, not on catheter, presented with complaints of fever with shivering, lower abdominal pain, moreover the right side of the abdomen, which is radiating spasmodic type of pain, radiating from right loin to groin, associated with nausea and multiple episodes of vomiting. There is no history of constipation or loose stools, history of decreased urine output from today morning onwards. There is no history of recent travel or food intake from outside, and no history of dysuria and increased frequency of micturition, no history of blood in urine. And patient is non-case of diabetes and hypertension on metformin plus glimepiride combination and hypertension on telmisartan 40 mg. On examination, patient has no pallor, no pedal edema, facial puffiness, per-abdomen tense, distended and non-tender, no renal angle tenderness, no guarding rigidity or bowel sounds present, chest, air entry bilaterally equal, CVS S1S2 heard with no murmur, CNS, no focal neurological deficits. So we got an diagnosis and urine routine also shows numerous pustules.
Okay.
So we and urea creatinine level is urea is around 65. So at that time pre-renal component is also ruled out.
There. All right. Because the patient is producing urine as well, so we can correct the fluid deficit and treat him with IV antibiotics and observe.
And right HUN with calculus also there for that
urological intervention will be required. Right. So we have a patient with urosepsis. Okay, so urinary tract infection.
Yes.
All right. So before we start the topic, if we look at the gender predisposition, which gender is more predisposed for urinary tract infection?
Females are more susceptible to urinary tract infections because of the shorter urethra and
right. And we always have learned from our MBBS days about asymptomatic bacteriuria. So what is that?
Asymptomatic bacteriuria, there are three definitions, like the presence of more than 10⁵ colony forming units per ml of a single pathogen on two successive clean catch urine cultures in a woman without in asymptomatic female. But if the presence of more than 10⁵ colony forming units per ml on one clean catch urine culture in asymptomatic men. But if it is a patient is catheterized, if it's a catheterized urine specimen, then more than 100 CFU per ml of a single isolate is of asymptomatic in an asymptomatic catheterized patient.
Yeah. In these patients, whom will you treat as UTI?
In case of pregnant woman, we have to treat, and immunocompromised and debilitated patients we have to treat.
Start there. Right. Very good. Urinary tract infection, we know that there is a gender predisposition. Along with this, which other risk factors will be involved in patients who present to you? Which subset of people presenting to the ER with fever, with chills, will have more predisposition to UTI? Can you name a few conditions where
patient is, if it is immunocompromised and if it is any stroke patients like
so the patients
neurological
immunosuppressive drugs, if the patients have any other comorbidities like diabetes mellitus, then they have more predisposition. If the patients are persistently in nursing home stage,
indwelling catheters
are there. If the patient has severe stroke and they are immobilized, then they have more predisposition. Any anatomical variants can also have predispositions. If at all any particular organisms, unlike the usual organisms that can cause UTI like E. coli, Klebsiella, atypical pathogens, if at all they previous history of such infections are there, then they have a predisposition to UTI. And also if the patients are resistant to normal antibiotics like ciprofloxacin, if at all any culture insensitivity report prior has shown such things, then they have a higher predisposition to UTI.
It's also mentioned that recurrent UTI is not alone is not a risk factor, but additional risk factors are there. Then recurrent UTI is also a risk factor for complicated UTI.
All right. Okay. Yes. Move ahead. What else do you have to discuss?
And next, we also know which are the clinical features of the urinary tract infection. Cystitis, which is the infection and inflammation that is isolated to the bladder, which initially there will be colonization of the urethra by the pathogen from the genitourinary system, and that will migrate into the bladder. And the other thing is the urethritis, which is more commonly associated with the sexually transmitted diseases. And
right. So most of the UTIs are ascending infections. Okay.
And there will be
a lot of sexual history that has to be taken. We'll have to take up.
And the clinical features for urethritis is dysuria, urinary frequency without vaginal discharge or irritation. Then the probability of cystitis increases to greater than 90% in females. And pyelonephritis is another entity, which is the infection of the upper urinary tract, the infection of renal parenchymal and pelvic calcium system. The patient will present with flank pain or renal angle tenderness with or without fever, and positive culture more than 10⁵ CFU per ml with nausea and vomiting. Can be diagnosed as pyelonephritis, and it can progress into acute bacterial nephritis, renal abscess, emphysematis, pyelonephritis. So emphysematis, pyelonephritis and all is an
neurological
emergency.
Yes.
And in that case we have to proceed with an imaging of CT. CT have to be done. And we have to discuss about uncomplicated and complicated UTI. In uncomplicated UTI is in a patient without any structural or functional abnormalities and within the urinary tract, and also on kidney parenchyma without any relevant comorbidities and not associated with the genitourinary tract instrumentation.
Right.
And
that would be uncomplicated.
Uncomplicated UTI. And in complicated UTI, there will be some functional or anatomical abnormal urinary tract or infection in the presence of comorbidities that place the patient at a risk for more serious adverse outcomes.
Right.
And risk factors we already discussed, and there is also one catheter associated urinary tract infection that will occur in a patient whose urinary tract is currently catheterized or has been within the 48-hour period.
Has been removed within the past
48 hours. And we also have to think about in our ED that the best way to prevent the urinary tract infection in catheterized patients is you have to follow a strict protocol to whether to catheterize the patient, precautions and also whether catheterization is needed or not.
Very much required or not. Right. Okay.
And recurrent UTI is another entity, that is 2 uncomplicated UTI in 6 months or 3 or more uncomplicated UTI in 12 months period. And there are 2 classification, relapse
or UTI, two subsets are there. 6 months?
6 months. Two uncomplicated UTI in 6 months or 3 or more uncomplicated UTI in 12 months.
Okay. Then there is reinfection
and relapse. Reinfection is more common than relapse. And relapse is a recurrence of UTI within 2 weeks of treatment completion by the same organism from a focus within the urinary system. If it is reinfection, it is a recurrent UTI caused by a different bacterial isolate or by the previously isolated bacteria if it is after a negative intervening culture or a period of more than 2 weeks between the infections. That is reinfection. That is more common than the relapse.
Okay.
And the etiological agents are also there. In case of uncomplicated UTI, Escherichia coli, Staphylococcus saprophyticus, Klebsiella pneumonia. In case of complicated also, E. coli, Enterococcus, Klebsiella pneumonia, Candida species. Catheter associated, E. coli, Enterococcus, Coagulase negative staph, Candida. Recurrent UTI, same as depending upon the patient's risk factors, it will be there. And next we have to discuss about the diagnosis. Usually the diagnosis is history plus lab confirmation, but in ED we will do the history and physical examination, and supportive lab will be do other than the confirmatory urine culture. Urine culture is indicated only in patients of sepsis and more debilitating conditions and all. We'll proceed with the urine culture.
Has a serious infections
and resistant to antibiotics and all, we'll do urine culture. Otherwise empirical treatment will help.
Yes.
And some others advocate lab confirmation to reduce the growing problem of the antibiotic resistance also. We have to keep that also in the mind. And delaying treatment while waiting for the cultures is not practical in ED.
One issue with catheter related infection is that these patients might have recurrent UTI over the course of years. And what happens is, because you've been giving a lot of antibiotics, the chances of them developing multi-drug resistant UTIs will be very common in catheter. So by default, you'll have to treat them. If at all they go into sepsis, you'll have to treat with higher antibiotics. Keeping that in mind. Yes.
And while assessing for the urine analysis, we have to collect the clean catch midstream voiding specimen. And we also have to think that bacteria in urine double each hour at room temperature. So we have to refrigerate it. If not, we are sending them directly to the lab. And also the normal urine analysis ranges are there in RBC, female and male. In female 0 to 5 level and in male 0 to 3 levels. WBCs is 0 to 4 per hyperfield and bacteria is none, and leukocyte esterase and nitrate test is none.
Okay, leukocyte esterase and nitrate are they very sensitive indicators?
They are not that much sensitive. We can't use it as a screening tool, but it is very specific. Specificity is
right.
And also,
what is in case of cystitis, what would the USG finding be?
There will be irregularities in the chronic cystitis, thickened and with
bladder wall will be there, with free floating echoes will be there. So you can correlate clinically with that findings if you have it, right?
And also,
let's proceed to the treatment then.
Treatment, yes. In treatment, we can select the antibiotic depending upon the organisms and patient's ability to adhere to the treatment regimen. So, there is a table in the Tintinale that is dividing into adult, female, and which with uncomplicated lower cystitis. We can start on nitrofurantoin. Nitrofurantoin 100 milligrams twice a day for 5 days, or we can start on trimethoprim sulfamethoxazole combination DS, that one tab twice a day for 3 days, or fosfomycin 3 grams in single dose, whichever is available. We can start on that in case of lower cystitis with uncomplicated. But in case of adult female or male with lower cystitis and upper pyelonephritis complicated UTA, we can hike up into higher antibiotics. And also that is we can start on fluoroquinolones like ciprofloxacin 500 milligram twice a day to 5 to 7 days, and levofloxacin 750 milligram once a day into 5 to 7 days, and trimethoprim sulfamethoxazole combination, amoxicillin clavinate and cefpodoxime. And usually in our state we will not start with levofloxacin since it is a second line drug for TB. And in case of adult female with lower urethritis, we can start on ceftriaxone 250 milligram IM plus azithromycin 1 gram single dose, or doxycycline 100 milligram. And in case of complicated UTA, we can start on ceftriaxone 1 to 2 grams IV once daily, or we can hike up into piperacillin, tazobactam, ertapenem, imipenem, or meropenem, carbapenem combination.
Okay.
Drugs. That is the treatment.
Make sure that first dose is given, but after that the subsequent doses
will depend upon the creatinine clearance.
Okay.
And treatment duration is usually 5 to 7 days, but in case of complicated, it will continue with 2 weeks and all 7 to 14 days.
Right.
And patients with the catheter-associated urinary tract infection, we have to replace or remove the catheter prior to the collection of the cultures or initiation of antibiotics. And if there is any relapse, treat with alternative agent. And if there is recurrent UTI in females and there is any use of spermicide with contraception, we have to use the alternative method of contraception in case of recurrent UTI.
We'll have to advise, on follow-up.
And if most of the patients can be discharged with adjunctive therapies like increased fluid and frequent voiding with antibiotics, and also we can give the oral bladder analgesic also, pyridium 200 mg TID, and ask the patient to return to ED if there is any increasing pain, fever or vomiting. And we also have to explain them the complications of acute pyelonephritis. But otherwise, if the patient is pregnant, we can start on, if there is asymptomatic bacterial symbol cystitis, we can start on amoxicillin or cephalexin.
Okay. And also we should give them clear instructions on how to maintain cleanliness and hygiene as well. Anything else that we have to add?
That's fine. Okay, thank you.